I believe in the house it's Gerard Gibert, host of MidDays, who comes to work a little bit earlier this morning. Good morning, Gerard. How are you, sir?
Morning, Paul. Yeah, working a little overtime today.
You remember those that soundbite there of Barack Obama and the constant, we're going to save you $2,500. I do not think that materialized.
It did not age very well, as the saying goes.
And she was supposed to be saying that you can read the information, and we'll tell you about the information after it's passed, but I chose the wrong one on that one. Listen, first of all, kudos and congratulations on a great article. I read the article. It was lengthy. You put a lot into that. I said earlier, I think you've surpassed what a column is. You can put that on a hard binder and sell it as a book. But it was one of the best that I've seen. And I wish we had more time to go over all of that. But some of the high points in here that we want to talk about is, number one, thinking out of the box and what do we do about it. So your thoughts on this? Yeah,
well, first, appreciate that. And just to, for perspective and background, you may recall that my very first appearance on the network on your show was in 2009, and it was discussing health care. Yes. Before the Affordable Care Act was passed, before it was enacted. And that's because, as I point out in the column, I had just become informed, shall we say, by reviewing candidate Barack Obama's plans for health care reform, and was frustrated as a business person that no one really could answer questions. And I understand why they couldn't, and I talk about that in the column, that we just didn't know until we had more data that things codified and the Supreme Court likely would see a challenge and it's upheld, and just didn't have all the details. And I was trying to make business decisions based on what could be a significant increase in my expenses as a business owner based on what Barack Obama actually desired. Now, that didn't pass exactly how we wanted it. Thankfully, a lot of people are probably surprised to learn what we got is a much watered-down version relative to what his and the Democrats' plan were. In fact, what they originally wanted was so far to the left, even Harry Reid at the time, the Senate Majority Leader, Democrat from Nevada in the Senate, he was skeptical. He wouldn't even put it on the floor. So what we got actually is a mild version of the Democrat wish list. What I really talk about in this article more than anything, about half of it, as you know, is just background. Here's kind of what the Affordable Care Act was all about. The sound bites you played before we went live sort of told the story. Yeah, we didn't get the $2,500 decrease of premiums. In fact, quite the opposite occurred. But what I talk about in here is, in Mississippi, usually when we discuss the topic of health care, it always, as you know, Paul, always devolves down into to expand or not to expand Medicaid. That's pretty much what we talk about. We don't really think beyond just Medicaid expansion. And the fundamental challenge we have in Mississippi is we have a large uninsured population. We're like fourth in the nation. About 11% of our population is uninsured, but they still get health care, and they don't pay for it. That's what happens. And so we end up paying for it through our commercial premiums, or hospitals and medical providers just absorb that. So my ideas were around how can we get these people covered so that the hospitals and the providers are being reimbursed, because even though a lot of people say we need to just implement a free market in health care, I'm all for that. But we have this law. It's called EMTALA. Now, folks in the medical world know this like the back of their hand. The Emergency Medical Treatment and Labor Act, passed in 1986, championed by President Ronald Reagan. Many people are surprised to learn that. What it basically says is, if you show up at the hospital in an emergency room, they've got to stabilize you. The hospital, whether you pay or not, you're going to get treatment. They don't say, hey, you're having a stroke. Can you pay us before we treat you? That doesn't happen. They treat you, and then they concern themselves with how to get paid later. So until hospitals are no longer required to treat people that don't pay, we can't have a free market. I can't name another business out there that says, oh, yeah, we'll provide you these goods or services. You don't have to pay for it. There's not another industry like that. That's not the case in healthcare. They are compelled by federal law to deliver services without being paid for them. So how do we offset that? How do we deal with that? Well, the way is to get people insured. So they have some way of reimbursing to some extent, and that's what I really focus on in the column.
Yeah, and also there is there's some flexibility too that we've learned over the years. When you talk about uncompensated care, at the end of the year, that individual hospital, is figuring out what their cost was. Boy, that is so subjective. I've learned over the years that a guy comes in, breaks his arm, he has no insurance. They've got to do it free. It may cost $1,000 if you've got insurance, but $40,000. I'm being ridiculous. $5,000 for him, so they can exacerbate or escalate or increase that uncompensated care. So at the end of the year, the hospital can say, "Look how much we lost."
Yeah.
Is there flexibility? Do they do that?
You could line up 5 people and ask them from a hospital and ask them what the cost is of some suite of procedures, and you get either no answers or 5 different answers. There's no doubt. It's incredibly complicated, and anybody that gets all these explanation of benefits documents and bills and stuff, they scratch their head like, what does all this mean? There's no doubt that that's a problem. But here's what I can tell you. A lot of the conversation in Mississippi is about the rural hospital specifically, that they're struggling economically. That's absolutely true. I've looked at the financial statements at a number of hospitals in the state of Mississippi, both rural and urban. They're all upside down. They're all losing money. I say all. I don't mean 100%. But it's not a problem that's unique just to the rural areas. I talk about in my article, the renowned Cleveland Clinic lost $1.2 billion last year. Now, they're not in the rural areas. Yeah. Half of the hospitals in California. are upside down. A third of them are at risk of going under. Several have in the last couple of months. So this is a nationwide problem. It's not unique to Mississippi, and there are a lot of different factors. But in Mississippi, we do have a lot of uninsured care that is a problem. But even Gulfport Memorial, I'm not picking on them, but $400 million last year, lost $60 million.
I remember reading where some of the top hospitals in the state of Mississippi were the number one in revenue in the nation at one point. It's maybe 10, 15 years ago. But there were some of the top ones in the nation as far as revenue. How important does the elimination of CON play into this?
Yeah, and I discussed that in the article. It's something I have advocated for, it seems like, for 20 years. And we get close, as you know, every year and can't get it across the finish line for the audience. The Certificate of Need laws really exist in the state of Mississippi and require essentially permission from the Department of Health, authorization, if you wanted to, like, add beds, build a hospital, buy certain equipment. It's a very complex set of regulations. But the bottom line is it to some extent limits availability of care. Here's what I'd say about that, Paul. While I still believe we ought to do that, I think we ought to repeal the CON laws just on the basis of principle, that it just introduces more free market into health care. I'm not so sure there's a lot of health care providers just lined up to set up shop in Mississippi. We got the most unhealthy population, and reimbursement rates from commercial providers are the lowest in the country, and a lot of people don't pay. That just doesn't sound like a target-rich environment to set a new business up.
Lost leader item is what it's called in the private sector. Well, on that same point, though, when you say the same thing about one of your recommendations, and we've talked about it, being able for the consumer in the state of Mississippi, much like their car insurance, to be able to go across state lines and anywhere we wanted to buy health insurance, and the viability of that, you put it in your article. And can you talk about that when we come back?
Yeah, absolutely.
Let's do it. Gerard Gibert, more. Back live with Gerard Gibert, host of MidDays, and we were talking about his article. By the way, somebody asked me how to get to the article, and it's real easy. Go to supertalk.fm on the website. Click on News. There's not a banner for opinion. It's under News. Just click on the news banner where it says stations, shows, sports, weather. Click on News, and it will go down to the opinions and the newly posted column there with Robert St. John, Lieutenant Governor, Brian Lamar, and many other people who are doing some opinion columns on there. So that's the way to get to it. You do write here that the average annual price of health insurance premiums for last year, for single coverage, $8,435. For family coverage, $23,968. Incredible.
That's right. And that's on average. I mean, like in New Jersey, it's approaching $30,000 for a year for family coverage.
In sometimes facts we don't like because facts are facts, and if you like them or not, they're there and they don't go away. But with every good idea, sometimes there's problems, and it sounds like a good idea. Let me do my health insurance the way we do our car insurance, no matter what the company is, regardless of where they're located. Then you get into the situation where some people who know the industry say, okay, then certainly now with AI and everything else, those companies can pick off the healthy people in the state of Mississippi, and what are you left with? So it's not as easy as it sounds, but is that something to look at and think out of the box?
Not really, and I'll explain why, and I talk about it in the article. What people want, if you think about the value of insurance, health insurance in particular, and it's totally different, by the way, than automobile insurance, but health insurance. You go to the doctor treats you. Before you walk out, and when you've arrived, you've already provided all your insurance credentials and so forth, and you may have a copay, you may have a deductible, but in general, what's going to happen is if that provider, that doctor, that hospital, that clinic accepts your insurance, meaning they have a relationship with your carrier, they're going to file it on your behalf, wait to get paid from the insurance company, and you're not out of pocket. That's what people want. However, if you have insurance that provider does not accept, then you got to pay out of pocket. Nobody wants that. They don't want to. They don't want to write a check or give them their card when they leave. They want to know you're going to file this on my insurance, and then I'm going to find out how much I owe, the so-called patient responsibility. So the challenge is not so much that we need more insurance companies to compete. It's that they don't want to come here because they got to set up this provider network, and the providers are saying we don't want to deal with it anymore. We got enough. And most of my physician friends, Paul, this is what scares me. They all are convinced we're headed to government single payer. They think that's where we're headed within the next 10 years, and which would eliminate the private insurance market altogether. That has been the Democrat dream, by the way, in health care reform, so-called Medicare for all, for 30 years now.
George, can we get to a place that's better than where we are without addressing the PBMs?
Well, that's certainly a big part of the healthcare industry. That it's a Byzantine system. I know you've interviewed Robert Dozier, the head of the Pharmacy Association. I have too. It's certainly a problem that needs to be uncovered. Here's what happened. When the Affordable Care Act was passed, it essentially regulated the profit of insurers. A lot of people are surprised to learn out, and I discuss in the article, just how little profit is created in the insurance industry. It really kind of is a bad industry from an economic and financial perspective because it's not very profitable. But because the federal government says, look, 80% of what you take in premiums, you got to pay out in claims, you're thus limited on your profit. Now, what they did is they said, okay, if you're going to limit us on our traditional core business here, we're going to get into other businesses. And they start buying up these PBMs. And that's how they essentially augment their profit. And you've got this kind of vertical integration that's sort of mysterious that nobody really understands. Yes, that's a problem. And it was largely driven by this limit on profitability imposed by the government. I know, shocking, when government gets involved in things like that, we have the old unintended consequences.
Look in the book of Centene if you want more information on that.
That's exactly right.
Yeah. So there was a couple of other things, and before time runs, because there was a couple of other things I wanted to ask you. In the analysis of this, or the finality of it, of other thinking out of the box. Now, you guys are going to be talking more about this on your program.
Yeah. Yeah, so, and again, my focus here was, you have two issues. You've got the cost of care that everybody is upset about. You played the clips. We're going to lower your premiums by $2,500. Obviously, that never materialized. In fact, I don't know that there's been a year where they haven't increased. It may have been, minimally, but as far as I know, they continuously increase. So you got that issue. How do we get the cost down? And then you got the other issue, which is we got a lot of folks that are uninsured that are receiving services. They're not paying for it, and those costs are essentially being absorbed by the people who are paying for it, including the federal government and its payment of what are called disproportionate share payments, which to some degree offset those undercompensated and unreimbursed
You
services.
had any pushback on going to Canada to get your using Canada? Oh,
I haven't heard about that, but Florida just did that. They just got waivers from CMS to pick up drugs in Florida. What I suggest is we have these improvements, enhancements in the subsidy model in the exchanges, which came about in the Inflation Reduction Act. You didn't hear a lot about it, and I go through some details on that. In lieu of expanding Medicaid, we should work to figure out a way to push people into the exchanges. The problem, Paul, in the exchanges is that the carriers that sell there in Mississippi, do not have a robust provider network. If we could persuade Blue Cross to sell coverage, which has the most robust provider network in the state, if we could persuade them to sell coverage in the exchange and in lieu of Medicaid expansion, push the uninsured that qualify based on their income to the exchange to buy coverage, we could solve the uninsured problem. That's an approach.
I do feel this, being around as a Mississippi, both of us are Mississippian for quite a long time, that we are getting better on changing things, and we are getting better on thinking out of the box. It's just a slow process.
Yeah.
But one of the other things is when you start doing, as a baseball guy, you start doing the analytics for Mississippi. It's very difficult sometimes where we can be replicative from even Arkansas, certainly Vermont, and people. We are our own special state, carrying more poverty than anybody else. So you have to figure that in. So we don't have to duplicate what they have, but just take the area. I can say this from from school choice to education. To healthcare. Do what is best for us.
Sure. I totally agree. Every state's got a different set of circumstances. You know, in our state, not only are we the poorest, but we're the least healthy. So, one of the problems is, hey, come to Mississippi. Everybody's sick, and a lot of people don't pay. I mean, it's not, really a great place to set up shop, and that's why we have problems. We've had our government even invest money in trying to keep our doctors and our nurses here, and all sorts of programs to that effect. I mean, it's a tough deal.
Let's end with some good news.
Yeah.
What do you think about the special session this morning?
Yeah, I have some questions. I think I heard Senator Sparks say this is a home run, a grand slam. I think is actually the way he termed it. I think that we desperately need investment in our state. We need high-paying jobs. I think that is the path to solve, honestly, all of our problems, be it health care, education, quality of life in general, opportunities for our children so they don't leave our state. I think this is a good deal. Now, the devil's in the details, as you know. I did review last night. I was sent the presentation that MDA delivered to the legislature yesterday. I do have some questions about the clawback provisions that I'm still not clear on. I really feel like that any sort of investment on the part of the state and taxpayers like this needs to have some protections, some guardrails in case the company does not meet its obligations and fulfill its responsibilities under the terms of the agreement when you're investing that kind of money. So I have some questions about that, but overall I think it's a good deal for the state.
Do you think those clawbacks are even more of an issue because of what they're going to be building as far as EV batteries?
I mean, it's possible, but I don't I don't think the state should be in the business of bearing that responsibility as far as the viability of the product being produced. That's what the private sector does. But we should have some protections, and I got questions about that. Based on what I saw, I'm not quite as comfortable with the protections we have. It looks like we have protections for the grant portion, but not the tax abatements. That's where I'm concerned.
Even in the conservative era of Haley Barbour, when it came to some of the green technology, we did have a problem, as you well
that's exactly
remember.
Right, and we don't want to repeat that.
All right. More with Gerard, and that'll be at 10 o'clock. Man, thank you so very much for coming in early. Thank you.
Appreciate it, Paul. Thank you, man.
You got it.